Okay. Hi, I'm Louise Kao. I'm from Indiana University, and I have to say it's a little bit frightening that everyone's going to be forced to read something that I wrote. Anyway, that being said, drug-induced QT prolongation is something that we're all familiar with, that we've all taken care of. I won't belabor the pathophysiology. We're all well aware of how the action potential correlates with the QRS, with the different phases and the different ions that are affected. The QT interval is most often affected by the R to R interval, and this oftentimes leads to the need for heart rate correction at the extremes of heart rate. Two formulas exist. Bazette's is the most commonly used, which is the QT over the R to R squared, but Frederica's is actually more accurate at the extremes of heart rate, and that's the QT over the cube root of the R to R interval. So QT prolongation, especially drug-induced, typically results from potassium efflux blockade. There are actually multiple potassium channels at work here, and blockade of this often leads to prolongation of the QT interval. So why is this concerning? As repolarization is delayed, that gives you ample opportunity to develop triggered activity. So if there are early active depolarizations that would develop, rather than being suppressed, they have ample opportunity to propagate and trigger aberrancy, which may lead to torsade. This is a depiction of a U wave that you can see and a long pause that often precede the onset of torsade. So QT prolongation can be thought of as being either inherited or acquired. Inherited QT prolongation, this is the population of people that have congenitally altered cardiac ion channels, sodium, potassium, even calcium. The hERG mutation, hERG stands for human ether agogo, which is IKR, can also be inherited, but this is often implicated in the acquired QT prolongation. People can be silent gene carriers, whereby they don't necessarily manifest anything abnormal, but they have a congenitally altered channel. And this one can be sympathetic triggered. So the classical history might be the person was scared and then they dropped dead from their dysrhythmia, which is why this can be often treated with beta blockers. Acquired QT prolongation is typically drug-induced, but it can be triggered by actually bradycardia. As you lengthen the R to R interval, the dysrhythmia could propagate. So this is why you would treat this one with increasing the heart rate by overdrive pacing. So long QT syndrome has been thought to be associated with 3,000 to 4,000 deaths per year in the US, but it's actually much higher probably. This is just something that's very difficult to study. There have been some population studies that have looked at associations. So in a population of people with cardiac disease versus not, the cardiac disease population would tend to have a longer QT interval. People with longer baseline QT intervals, that population of people has been shown to have a higher mortality, but cardiac disease is obviously a big confounder in there. They've also looked at prescribed medications and found that there's incidences of sudden death that you can extrapolate from pharmacy records of what medications patients have been recently prescribed. So although QT is a risk factor for torsade, and torsade may present as sudden death, QT is only a surrogate marker. There's not a linear relationship, so it's not like as your QT gets longer, your risk of torsade in a linear fashion goes up. And again, this is very hard to study because people, when they have a sudden death, typically aren't wearing any kind of a cardiac monitor that you can look at. A lot of patients who have sudden death don't necessarily get an autopsy to look for other causes, etc. QT dispersion is a concept where you look at the longest and shortest QT interval on 12-lead EKG and look at what's the difference between the longest and the shortest interval. If somebody has an increased QT dispersion, this may actually give them more potential to develop triggered activity because then your repolarization is occurring at all different kind of phases at any given time. So it's thought that an absolute value of 100 milliseconds of QT dispersion or a 100% increase from your baseline may put you at increased risk for developing a dysrhythmia. Other well-known risk factors for torsade: female sex, bradycardia, electrolyte imbalances, and structural heart disease. And the drug-induced QT prolongation is most often due to blockade of that delayed rectifier potassium channel, which is encoded by the hERG gene. But QT prolonging drugs don't always give you a risk for torsade. For example, amiodarone is often cited as a drug that prolongs your QT interval. In fact, that's kind of its mechanism, is by working on repolarization. But because it does so kind of in a uniform fashion, so it doesn't really increase dispersion, it's not associated with development of dysrhythmias in general. There are other broad categories of drugs that are commonly associated with QT prolongation, some of which are non-cardiac drugs, like anti-infectives, antihistamines. Drug interactions play an important part in the understanding of drug-induced QT prolongation. There are pharmacodynamic interactions, which is basically like for example, you would add two QT prolonging drugs together and someone would take both of those and that would add to the effect. Or if you take a drug that prolongs your QT, but then you take another drug that gives you hypokalemia, that would be an interaction. Pharmacokinetic interactions would be an example of one drug inhibiting the other's metabolism. So a famous example of this would be the whole terfenadine-erythromycin combination, where the one inhibited the other's metabolism and both of them at baseline cause QT prolongation. Another concept that's been written about a lot in the QT prolongation literature is repolarization reserve. And what this refers to is that individuals may have a genetic predisposition, a genetic polymorphism, which may be unmasked when you add a trigger such as a drug. So these people may have a completely normal screening EKG, but when they are triggered in some way, they may develop QT prolongation and torsade. And this can actually give you the truly idiosyncratic and unpredictable cases of sudden death. So the clinical implications, drug treatment, you need to weigh your risks and benefits, be aware that drug interactions of what they are and that what's out there. You might consider getting a screening EKG on patients, follow them for signs of syncope or pre-syncope. And to treat torsade, magnesium as a bolus, repeat as needed, correct hypokalemia. For acquired QT prolongation, pacing is recommended, whether with mechanical pacing or isoproterenol or something like that, possibly defibrillation. And finally, QT prolongation torsade is actually the #1 reason for recent drug withdrawals or restrictions. And as such, when new drugs are coming out, they're usually very rigorously tested now for the potential to cause QT prolongation. So what they'll do is they'll do hERG studies on channels, cells, isolated hearts, and animal models prior to performing clinical studies. When they do the clinical studies, they also look very closely at the QT and how it changes. They also look at drug interactions. How is this drug metabolized? And in the setting of this metabolism, giving an inhibitor, will that affect the QT? Okay, thank you.